All right, good morning, everyone. I am well aware that I am the last thing standing in between you guys and a break, so we will get right into it. I have nothing to disclose, and you can see my whirlwind tour of objectives. We'll talk about management of cancer pain in the next 20 minutes or so. As you all know, this is incredibly common. Looking up these statistics for this talk, it was a little surprising to me how common all throughout the disease. So whether we're talking about curative treatment or very advanced metastatic treatment, the majority of our patients are going to have moderate to severe pain at some point. Most of my talk will be focused on treatment, which I think makes sense, but spending a couple slides just talking, making sure that we take a pause. When I see a patient in a cancer pain crisis, I want to jump to fixing it right away, but taking a little bit of an inventory, doing a thorough physical exam, taking a step back, seeing, do I actually need to get a little bit more imaging here? Just making sure that before I jump right to treatment, I'm able to really target the effective therapy. And then also making sure I'm classifying the pain. Is it nociceptive? Is it somatic, visceral, inflammatory? Depending on the answer to those, I can certainly target therapy. So again, I want to make sure I'm looking at all the treatment modalities before jumping in kind of on a premature closure pain treatment. I like the WHO pain ladder. I like to keep things simple here, so there's just 3 steps. I like the first step being non-opioid, plus or minus an adjuvant. Second step being an opioid, again, plus or minus an adjuvant, and then increasing the dose of all of those. WHO recently changed this. They used to have 3 steps, including a weak opioid. I will tell you, I'm very, very biased against weak opioids, that it feels to me like rolling the dice. It's sort of analgesic roulette. Patients who have very high metabolism might get great pain relief, might also get a ton of side effects, might get some serotonin syndrome for your work. Patients who are low metabolizers might not get as much effect. So I would say in general, I don't see a reason for using weak opioids like tramadol or like codeine, and WHO agrees with me on that. They say we're eliminating the second step that involves weak opioids. But we've got plenty of other options available. There's certainly a pretty broad pharmacologic spectrum of what we can work with, so I will try and make sure that we touch on most of these in the rest of the talk. And also keeping in mind that it's multifaceted, that certainly there's a variety of pharmacologic agents that we can work with. There's opioids, there's non-opioids, and there's a variety of non-pharmacologic treatments. So wanting to make sure that we're involving our interdisciplinary team as well, if there are other modalities which may be helping us here. Why I have a job is really this space in between under medication, and over medication. This is sort of my entire job, why I did a subspecialty fellowship. So most of our patients who have pain, it's going to be pretty persistent. They're going to have pain throughout the day, and we want to make sure that whatever long-acting opioid we're giving is covering their pain. But they're also going to have spikes of pain when they're moving, when they're talking with patients more, if they have to get up to go to therapy. So they're going to need to make sure that we're covering with short-acting as well. And I'm wanting to make sure that I cover that pain within that therapeutic window, that I'm not over-medicating and I'm not under-medicating. So I'm a visual person, so I like to see this kind of written out to give me a sense of what I'm doing. But I always like to use cases and make it real. So Julie is a patient that I saw a couple weeks ago, hopefully feels kind of familiar to the patients that you guys see as well. A middle-aged woman with non-small cell lung cancer who came in with some back pain in the middle of her course of treatment. So you do what I had suggested. You're doing a pretty thorough symptom assessment. It's it's an aching pain. It doesn't radiate. She went to see her PCP for this. And PCP said, oh, you can take some oxycodone, acetaminophen tabs. But she was really needing to take that pretty regularly around the clock with not incredible relief. She had a pretty normal exam, and she has known bony metastases that hadn't changed recently on her most recent imaging. So I won't make you answer out loud, but just think to yourself, if this were a patient you were seeing in clinic, what would be your next best step in managing her pain from these options? We've got some adjuvants here, we've got some long-actings, we've got some short-actings. So I'll let you think about it. My take home for Julie at this point was she was using short-acting opioids around the clock, so she really needs something sustained relief at that previous picture of that green. She needed something so she wasn't constantly just playing catch-up as she had been with just the short-actings. When I'm working with learners on this, we kind of think through, there's a variety of agents available. How am I going to think through? Do I have to have a patient who is getting most of her meds through G-tube, in which that's going to affect which long-acting agent I choose? Cost, a lot of insurance companies are cracking down on not starting with long-acting morphine unless there's a reason not to. And so wanting to make sure I'm not spending my patient's money not well. And if there's any contraindications, I certainly think of organodysfunction if they have renal or liver dysfunction as reasons why I might not choose morphine or oxycodone. But in this case, it's just pretty easy to deal with, nothing exciting. So I wanted to tally up her total daily dose of opioids and then figure out how would I rotate that to a long-acting. So at this point, I always tell my learners, the bad news is we gotta get out our iPhones, we gotta get the app out, we gotta get a calculator and total it up. The good news is this is like second grade math. We can all do this. But I find this helpful. I like to jump to when I first was seeing patients in a cancer pain crisis, I would just do whatever my gestalt was of just like start a long-acting based on how severe I think their pain was. But doing it in this way that's systematic, I think can be really helpful. In Julie's case, in my mind, I was thinking, she's just using a couple doses of Percocet throughout the day. But when I tallied up, she was actually using 60 milligrams of oxycodone a day, which is pretty significant doses to not have any pain relief. So this helped me to be a lot more accurate. When I'm thinking about equianalgesic dosing, I like this old school table. There's lots of apps that do this, but I like this because it works up and down, left and right, diagonal. All of these doses are equianalgesic to each other. So this is what I just keep in my head. So for her, because she didn't have any organodysfunction, I wanted to rotate her to a long-acting morphine. So we knew it's a 2-to-3 ratio. And so she was using 60 milligrams of oxycodone a day. So in general, she was using the equivalent of 90 milligrams of morphine a day in just short actings. It's a patient who is relatively opioid naive. The one caveat I give for this is just because a patient is tolerant to the effects and side effects of one opioid does not mean that they're tolerant to others. That we all have different proportions of mu and kappa and delta opioid receptors, and each opioid targets those a little bit differently. So each opioid may not affect the same patient in the same way. So in this case, she hadn't been on morphine before, and so I wanted to reduce that equianalgesic dose by about 25 to 50%. If it were a patient who I was a little worried about, if it was a frail elder, if it was on very high doses of opioids, I might reduce by more than 50%. If it was someone who I felt was in a total pain crisis and it was an extreme agony, I might reduce by less than 25% because I really wanted to get them to that dose a little bit quicker. So in this case, I calculated her total daily opioid equivalent as 90, so maybe decrease by 30% or so, and we'll do 30 BID. So I'll start her at 60 milligrams of morphine a day. And then I also want to make sure I'm escalating the short-acting dose as I escalate the long-acting as well. I see so many patients in clinic who are on 400 TID of OxyContin and 5 of oxycodone PRN. To me, that's a mismatch there. If they're needing such a high dose long-acting, we're going to have to escalate their short-acting dose as well. So my gestalt is 10 to 20% of whatever their total daily long-acting requirements are. I'll make that the Q3 hours PRN dose. And then wanting to make sure I'm thinking about adjuvants as well. In her case, bony inflammation pain, NSAIDs might be a helpful adjuvant. In general, I'm telling you all of my biases. I also don't use combination preparations very often because I'm worried that if we're increasing that short-acting dose, we're going to very quickly get to the acetaminophen ceiling, and I don't want to lead to acetaminophen overdose. But certainly we could uncouple those and have her take the acetaminophen separately as a standing dosing. And then I always remind myself the hand that writes the prescription for the opioid has to be the hand that writes the prescription for the bowel regimen. That I don't want to wait till my patients are constipated and tell me, forget it, I'm not taking opioids ever again, you backed me up. I want to give them at the same time, always. So in her case, we did 30 of the sustained relief morphine. We rotated her from that combination oxycodone acetaminophen to just a MSIR, a short-acting morphine, and then we added a couple adjuvants that I thought might target that bony inflammatory pain as well. So this continued to work for Julie for a couple months. I'd see her in clinic, I'd tally her total daily dose, and I'd fold that into the long-acting. And then a couple months later, she came back and she had gotten up to 90 milligrams of sustained relief morphine twice a day. And then I had bumped up her short-acting as well. So she was taking 30 milligrams of morphine short-acting pretty much around the clock. So she's getting up to almost half a gram of opioids. That to me is sort of the threshold of if you have patients where you're rapidly up-titrating, certainly involving your palliative care colleagues, we are happy to see these patients at this sort of dose or at any sort of dose. We're always happy to see patients. But in this case, let's kind of walk through the same exercise. It's helpful for me to see that the same basic math of the conversion works at low doses, it works at opioid-naive patients, and it's also going to work at higher doses. In Julie's case, she had also had some treatment-related renal dysfunction, so I was a little bit worried about the morphine. So again, you're seeing Julie in clinic. Her pain is escalating. You're worried about her renal dysfunction. What would be your next best step? can just in your head decide. So in Julie's case here, I was worried about the morphine. Both morphine and oxycodone have toxic metabolites that build up in renal dysfunction. And so I didn't want to add to that by either keeping her on the morphine or rotating to oxycodone. So I thought a fentanyl patch would be a really good option here. Again, I go back to my trusty old school equianalgesic table. For morphine to fentanyl, it's sort of apples to oranges because we're comparing milligrams of oral morphine to micrograms per hour of transdermal fentanyl. But in general, the rough and dirty estimate is that it's a 2-to-1 ratio. So in Julie's case, she was using about 400 milligrams of morphine a day, so that would be equivalent to about 200 micrograms of transdermal fentanyl again. Because she had never been on fentanyl before, I still wanted to account for that incomplete cross-tolerance. Fentanyl affects the mu opioid receptors and the kappa a little bit more, and so I'm not quite sure, given each of us have a unique makeup of receptors, I wasn't sure how she would tolerate the fentanyl. And because that's a pretty hefty dose to start a patient at, I did reduce by a little bit more than 50% in her case, so I started her at 125 microgram per hour patch. But to me, this is helpful to be able to do this math that I can feel really confident. I'm not just guesstimating. I can be pretty aggressive at up-titrating my patients because I know they can tolerate. It's based on what they've used in the previous 24 hours. Again, I'm rotating her long-acting, so I want to consider rotating her short-acting opioid as well. And in terms of oral opioids that are safe in renal dysfunction, for short-actings, morphine or hydromorphone is one that is considered one of the safest. Certainly methadone and fentanyl are kind of the opioids that don't have active metabolites in renal dysfunction, but of the short-actings, hydromorphone is usually what I pick. So I go back and I look at the ratio, so it's a 30 milligram of oral morphine to 7.5 of oral hydromorphone. She's taking 30 as a short-acting, so again, I could have started just with 7.5, but because this is a third opioid that she's never been on in the past, I again reduced for that cross-tolerance, so I started her at 6 milligrams of hydromorphone as needed. I can continue to do this. There is no ceiling for any opioids, but at some point, we're gonna get to dose escalation leading to adverse effects for all of our patients. I'm sure you've seen this. So we'll think through, if we get to that ceiling effect, and Julie's probably pretty close to that here, where she's using over 400 milligrams of morphine a day, we want to think through, are there ways that I can optimize the side effects management? We'll talk about that a bit on the next slide. And then are there ways that I can optimize analgesics? Are there non-opioids that I can use? Are there topicals I can use? And then are there any procedures that I can use for pain? If you're optimizing all of those things, you're optimizing side effects, you're adding adjuvants, nothing's working, then I might want to just choose opioid rotation. Part of this is a little bit of the art of medicine, so I'm not sure why, but some patients do respond a little bit better to one opioid than another, and so I think in this case it certainly would be a good idea to rotate if she's not responding well to escalating doses of fentanyl. When thinking about treating opioid side effects, I often see this is a very common consult for me in clinic of a patient who is allergic to literally every opioid. I think that is usually actually pretty rare, thankfully for me, but what often happens is people start an opioid, get a side effect from it, stop, start a new one, and so we're never quite sure of which opioid they really would tolerate. So I've ordered them. Sedation is usually the side effect that resolves the soonest. So certainly not talking about patients who can't keep their eyes open or have respiratory depression, but this is sort of that brain fogginess that comes on in the first day or two that you're starting an opioid. So I think counseling patients that this is going to get better within a day or two can be really helpful. And then if they still find that really fatiguing, then adding a little bit of a stimulant like a methylphenidate can be really helpful just to bridge them through. Then I've had some patients who are like, wow, I actually feel great. My pain's controlled and I have a ton of energy. So happy to keep them on the methylphenidate if that's helpful for them. Nausea usually lasts a little bit longer, opioid-induced nausea, and so usually it's a few days to a week that patients will experience this before it self-resolves on its own. But again, for patients who told me every opioid makes me throw up, I might start them on a tiny dose of a standing haloperidol or an olanzapine to get them through just that couple days or a week. Constipation for the vast majority of our patients with normal anatomy is never going to get better from opioids, so I always pair an opioid prescription with something for a bowel regimen as well. And then the more worrisome side effects, the delirium that you might see, I'm probably going to go back to reduced doses, or I might rotate to a different opioid, and then certainly I'm going to want to rule out other causes as well. And then always want to mention it, but with appropriate use of opioids, if you are never guesstimating wildly, if you are always calculating the dose, that patients have required previously and then folding that into the long-acting, I think this is quite rare to have patients get frank respiratory depression because of opioid escalation, but important to mention and know about. If you're doing all of that and pain continues to worsen, we'll talk about a couple adjuvants that are sort of my go-tos. Gabapentin, I also see patients in clinic who say, tried it for a week, didn't work at all. If you tried it for a week, that is certainly not a long enough titration. So I think gabapentin works incredibly well for neuropathic pain, but it is a beast to up-titrate. It has to be a start low, go slow up titration to get to therapeutic levels up to 3,600 milligrams a day. So it's going to take a while. This is going to be a several weeks up titration, which is annoying for patients, but if they can stick it through, can work pretty well. Again, insurance often require patients to be on gabapentin before they can try something like a pregabalin. But if gabapentin doesn't work well, I still really feel like this is neuropathic pain. I'm not sure why gabapentin's not working. I'll then rotate them to something like a pregabalin. There's pretty good evidence that gabapentin is not going to necessarily obviate the need for opioids, but it's going to decrease the doses required. And then even the trifecta would be adding something like an SNRI, like a nortriptyline, which might help really well with mood and also is going to help pain. So the three together can be really synergistic. So again, I might think about adding, especially for my patients who I worry about depression or anxiety. And then as we saw in our previous presentation, I'm wanting to make sure that we address total pain and suffering. And so certainly I want to address physical pain, but if there are other things going on in a patient's life where pain is expressing itself, I want to make sure that I'm being attentive to that. And also stopping to ask patients about, what does this pain mean to them? Do they feel that this is disease escalation? Is this that you're going to give up on me soon? Is that treatment is failing? And it might actually be the opposite, and you can break some good news to them that, maybe this is a flare because your chemo is working well, or this is just a temporary inflammation because of radiation. So I think the psychoeducation piece is also one not to miss if you have patients' pain that's continuing to worsen. We try all of those things. We are rounding the bend to the end, and our patients still have pain. You are not alone if that is the case. Up to a quarter of patients who very appropriately, their clinicians are escalating on the WHO pain ladder, you're still going to get to that third step and experience significant pain for a quarter of those patients. So a couple caveats there. The title of my talk is If Everything Hurts, but if everything really hurts, if you have a patient come into clinic and say, I can't localize the pain anymore, it's really everywhere. When I pull up my sheets at night, even just the sheets touching me hurts. That to me talks a little bit more about opioid-induced neurotoxicity. That to me sounds like hyperalgesia, where I would be worried. Something we see pretty commonly in the inpatient side at least. So you might have seen patients who have escalating doses of opioids who just have a little bit of myoclonic jerks, but it certainly can progress to confusion, to delirium, and then to that hyperalgesia where everything hurts. So I often will get called in to see these patients for a pain crisis, and people will think I'm crazy. I'm coming in to see a patient in agony, and then I decrease opioids. But in this case, I actually don't think it's worsening pain. I think this is neurotoxicity. And so I always want to keep this on my differential, especially for my patients where opioids have been increased pretty rapidly because their pain is progressing. It's not hyperalgesia in this case. It's not opioid-induced neurotoxicity. You're escalating, you're adding adjuvants. None of that works. I think that's also an excellent time to think about involving palliative care and rotating to methadone. I love using methadone. I think there's a lot of very strange pharmacokinetics. There's a lot of drug interactions, as you all know. So it's not something I do lightly, but for me, I really think of this as the gold standard for refractory neuropathic pain that can work incredibly well. Ketamine as well, I often will use as an adjuvant. If I have patients where I want to keep them on the same long-acting opioid, I like their adjuvants, but I want to use something extra. That really low doses can be helpful, and as we all know, the emerging evidence is showing can be really helpful for mood as well. In addition to all that, when I have refractory pain, I also want to make sure I'm thinking through those non-pharmacologic treatments, involving my interdisciplinary team as appropriate, and then thinking about interventional pain options. These are sort of the big 8 up here. I won't go through all of them, but the classic one we all think of is the celiac plexus block, especially for really highly innervated areas, for patients with pancreatic cancer who have a really highly innervated tumor. And I like to think through if there's a twofer I could possibly give. If there's a patient who's going for an ERCP, could I ask IR to do a celiac plexus block while they're already under anesthesia? So wanting to think through in advance. For patients who have back pain that I think it might be due to compression fractures, is there a time to think about vertebroplasty or kyphoplasty? pretty good evidence that on their own, these reduce the opioids that are required. So again, if I have patients who are starting to creep up in their opioid-induced side effects, this might be a way to bring that down a bit. But in addition to being pretty effective for pain relief, they're also effective for fatigue, for depression, for anxiety, for drowsiness. So there's really good evidence that for patients that you're worried about, thinking about interventional modalities on the earlier side before they kind of exhaust all of our other pharmacologic options can be really helpful. And then I'll just end by saying, in the same way that thinking about interventional modalities a little bit earlier can be more effective, I would argue that the same is true for palliative care. So not just for your patients with refractory pain, but if you're seeing patients where you're feeling that for any reason palliative care might be helpful, most families, once they see palliative care, wish it had been done sooner. So I would argue we are always happy to see any patients for any reason. We'll end there, happy to take questions if there's time.
Do we have any questions?
Thank you for a great lecture. So for patients with sickle cell disease, one of the things that I am challenged with, especially in the inpatient setting, is that they get a lot of itching with opioid analgesia. And of course, I hear a lot from the nursing staff. They're very concerned about giving them sedating antihistamines on top of their opioid analgesia. Have you found that there are tricks to help with that particular side effect?
It's a great question, and unfortunately, I don't know of any magical tricks. I think we have a bunch of topicals. Most patients find that topicals work minimally, but again, I think it's targeting and multi-agents. And I think it's also a time-limited trial. That I would agree, I don't want somebody on high doses of opioids and high doses of antihistamines long-term, but this might be a bridge-the-gap type of situation. It's a great question.
We do have a few questions from the virtual audience. One is using a CNS stimulant counteract effect of pain med?
It's a great question. In my experience, it does not. It will counteract the side effects of the pain medication is the hope. That if people are experiencing a little bit of opioid-induced sedation, that the CNS stimulates will perk them up. I think of it's not a magic pill. I tell my patients it's like a good strong cup of coffee. So I usually start people at a low dose of methylphenidate twice a day. So it's going to give them a good hour or two of energy. So people can also time it for if they know that they're going to work with physical therapy and that's going to be fatiguing and worsen their pain, so they're going to take opioids. It's a nice way to kind of bump them up and give them a little bit more energy.
Another question is, most oncologists do not prescribe fentanyl patch and barely use long-acting morphine due to concern of overdosing. Many institutional pharmacy guidelines also discourage the use of fentanyl patch. Any recommendations?
That is a tough institutional issue. I would argue that there might be a way to push back against that safely. I think part of why I made this presentation incredibly boring with the numbers is that is the safe way to do this. That I certainly wouldn't want to just guesstimate and start somebody on a 300 microgram fentanyl patch. But if I can justify this patient for the last week and a half has used the total daily equivalent of over 300 micrograms, then I can feel like I'm being very safe while I'm being aggressive. But I appreciate that those of you who are practicing in places where there are limitations and you're feeling like your hands are tied, that's a challenging situation. If there are ways to reach out to your acute pain colleagues or your interventional pain colleagues or palliative care to help advocate for change, I would support you.
Thank you so much.